Welcome back to Rural Health Today, our latest series of Rural Health Fractured. In this series, we're discussing how rural health is being fractured in every direction by the politicization of health and science, decline of resources for rural communities, deterioration of adequate insurance coverage, and so much more. As we take a closer look at the fault lines in our healthcare system, our guest will provide new perspective on how healthcare leaders can navigate these challenges and explore sustainable solutions. Today, our guest is Dr. Ross Ramsey. Now, Dr. Ramsey, President and Chief Executive Officer of a critical access hospital, but I'm going to tell you what, you're doing a lot more than what most critical access hospitals are doing. And I'm excited to have you here today with us. And I'm just, first of all, you were with us about a year ago, I believe, on the podcast. And you explained what is happening in your region, and we'll talk about that in a minute. But man, you build a new building, I think. You had a lot of exciting things going on. I want an update from you. Before we start with an update of your facility, why don't you tell us a little bit about your background, yourself, your hospital? Give us really an introduction of who you are and what does your health system look like?
Absolutely. So I'm a family physician by training and still practice every week. So when I finished residency, I came back to the area that I actually grew up in, which is near where the hospital's at, and started to practice. And I've been there ever since. I was our chief medical officer for 5 years. So I have a lot of insight on that side of things.
Yeah.
And then moved into more administrative work. So it has been a really exciting ride to get to where I'm at right now, but gives me a lot of insight as to what's going on the ground.
Yeah. Now, you didn't assume the responsibilities of your chief medical officer and CEO, right? You're not doing both those jobs, are you?
I'm doing both.
I figured you were. Well, last time we talked, you had a lot of exciting things going on, but one of the things that really was striking is the fact that you go and practice medicine. Is it every week now?
Yes, 2 days a week. I'm still out practicing medicine, seeing patients.
Yeah.
Patients love to see me. I love to see them, and it gives me a lot of insight as to what the community's thinking, maybe faults in the health system that we have and ways to fix it.
Yeah, I think it's a unique perspective. I often think, if only I was a doctor, because, invited to those meetings and having discussions, oftentimes we hear, well, you're not a physician, you don't understand CEO X, but you're in the position to understand. And I think that puts you at a very great position in your organization. And then boots on the ground, patient experience, you can deliver it and you experience it. So talk to us a little bit about maybe a fun fact about yourself or something interesting, because we have listeners across the country. What can they know about you?
Well, interestingly, when I grew up, I was not in healthcare at all. I actually grew up in a family funeral home. So our family owned a funeral home, right. And I wanted to get into it a little bit before they hit that point of their life. So anything's a win in healthcare.
Now, does your family still have funeral homes?
They do.
Do they really?
My older brother's a funeral director.
Okay, in your town?
In Harbor Beach, where our other
Beach.
hospital's located.
All right. Well, that's a fascinating industry. And a fun fact about me, I owned a monument company for about 10 years. And I started in the business of swinging doors at funeral homes and then doing removals. So, hey, we come from the same background, right?
Perfect.
Well, it's great to have you on the program today. And in this episode, we'll talk about how the trust between physicians, patients, and health organizations have been fractured in rural health and what it will take to repair that trust. Dr. Ramsey will share his perspective on how rural hospitals can build relationships with their communities and how it benefits patients to do so. We'll talk about health literacy, social determinants of health, and what all this has to do with rural health. So, Dr. Ramsey, let's just jump right into it. How have you seen the relationship between rural hospitals and their communities shift over your career? And would you consider the trust between healthcare organizations and healthcare consumers broken? Or how would you describe it today? So talk to us about it.
There definitely has been a distancing between the community and the hospital or health system as a whole. A lot of it, I believe, really has to do with the politicization of medicine, as well as now being seen as more of a service provider. I think some of that comes down to everyone's fear of walking into a hospital and a bill they might be left with. So they're really hesitant to come unless they truly need to. So that, I think, has created more of a distance.
Yeah.
I do think during that same course of the past 2 decades, there's also a lot more access to information that people have with the internet.
There is.
So in rural communities before, there was really no resource other than your local health system. So that's who they looked at. But now they have plenty of other options as well. So that's forced them to distance themselves some. Yet, interestingly, over that same period of time, there's a higher reliance on the health system from an economic factor in those small rural communities than there ever was.
I would assume you're one of the largest employers in your community.
In the county, we have 800 employees in a county of 30,000 people.
So you have to be one of the largest
We are.
participating. So there's already a brand equity that you have. Now, when you stepped in, your hospital was not, certainly not the degree that it is today in terms of the services that you offer. You stepped in. You built a newer hospital, right? Or an office building, or talk to us a little bit about that.
Yeah, so we have added we've expanded out a medical office building that we had over the last few years.
Yeah.
We're able to put in additional services, mammography, ultrasound. We've expanded lab access there. We added orthopedics there, walk-in clinic there. So we've done a lot over the course of the past year. This year, we're breaking ground on 2 new facilities. $50 million worth.
Wow.
Where we're doing some expansion and consolidation of services as well.
My goodness.
Over the past year, we did have Harbor Beach Community Hospital join our network as well. So they fall under me as well. So along with that.
Is that a critical access?
That's another critical access hospital. So along with that, we actually added 2 more pharmacies in those communities as well. So now we're up to 6 retail pharmacies that we have.
That's incredible.
In our network too. So we've really been expanding a lot of those services to bring things closer to home because we find that patients just won't travel, as is the case in most rural areas.
And the challenge is access to transportation, right? I mean, it's not maybe a desire, willingness. It's just you don't have the option of transport.
Absolutely. Those county transport services will get you to the county line, that's it.
That's it. And usually Monday through Friday, 8 to 4, no traditional weekends or anything of that nature.
And we're at the very tip of the thumb. So we're surrounded on 3 sides of our county by water. So there's only one way out and only one way in.
So why don't you talk to us about critical access? Because you have been on our program before, and a lot of the hospitals that we interview, big systems, PPS, et cetera, rural access hospitals. But when you talk about, the type of hospital that you operate, historically and traditionally, you don't find a lot of service lines with critical access, but you have them all. In fact, you shared with me ophthalmology. You do not see that typically in critical access. Talk to us about the difference in hospital systems. What signifies critical access? What are the tenets of it? What are the things that make it up?
And it's a designation by CMS, really from a reimbursement perspective. But it is a hospital limited to 25 inpatient beds in a rural area. There are some mileage requirements that CMS has for distance to the nearest hospitals. But ultimately, they know that your volumes are lower because you're in a rural area. So to help with that, they do a different type of reimbursement to help make up for that slightly higher overhead that you have. But ultimately, usually they're just core services and primarily outpatient. So for instance, we're 95% outpatient services.
That's incredible. Now, hospitals today are challenged by the one big beautiful bill. A lot of challenges that we're facing, but you kind of almost have a guarantee of certain types of reimbursement that are going to come to you, correct?
Correct. With Medicare, we have that guarantee. However, H.R. 1 really affects Medicaid.
Sure does.
Which it does not. We do utilize rural health centers as part of a critical access hospital, which does help with some of the cost of Medicaid and those physician clinics, but again, does not cover everything.
It doesn't. What percentage of your payer mix would you say is Medicaid and Medicare? Would you know?
Combined, we're about 65 to 70%.
All right, so it's similar to what we find in rural America.
Absolutely.
Of even, hospitals our size, 110 beds or et cetera. So a lot of issues right now that we're facing at the state and the federal level. We've heard a lot of rhetoric about waste, fraud, and abuse, right? And, we call it as it is here at Hillsdale, which is garbage, because we see the faces of Medicaid. And I was a face of Medicaid when my parents, 7 children in our family, father shot down at the end of World War II. Mother almost died giving birth to me as a 7th child. We were on Medicaid. We were a very poor family. And so we're not waste, we're not fraud, we're not abuse. Right now, that nomenclature seems to go out. Those are talking points that congressional offices are using. And it destroys the trust between hospitals and patients in many cases. They look at us, they pull our 990, oh, they're making millions of dollars, when our investment back in the community is huge, and the list goes on and on. So I want to talk to you about what we originally started out with, which was trust and the trust relationship that you spoke of. How does trust between a hospital and its community impact the organization? Let's start there. The staff, and most importantly, the patients, because I've seen that as those comments are being made by congressional leaders, waste, fraud, and abuse, the public starts to believe some of that. So talk to us about, maybe from your perspective of the corner of your world. Someone's listening from Texas right now. Someone's listening from places never even seen Michigan, right? Tell us about what your perspective is.
One of the great things about being in a rural community is that a lot of the community is your workforce. So they're your best PR person to have out there. So they know and see as well the lack of fraud, waste, and abuse in the system, and really how we work so hard to make great utilization of every resource we have. So along with that, they're the ones going out in the community, spreading the word that there's not all this fraud, waste, and abuse. In fact, it's simply we're struggling to get by at times. So they really are our greatest resource for that, and we're happy to have them as some of our spokesmen.
Absolutely. I think that's critically important to remember. We have a story to tell, both from an employee perspective as well as a patient. Let's talk about the patient, because you're a physician, and how do physicians play a role in patient trust and community trust? What would you say to that? I mean, when you're having physician roundtables, they have a piece of this, right?
Absolutely. And if you look at research, it's shown the number 2 profession in the U.S. in terms of trust are physicians. Number 1 is actually nurse. So if you look at that, in healthcare, we have the 2 most trusted professions in the entire country in our back pocket. So really, it's getting and leveraging those people to be able to be out in the community. When they're at the grocery store, people know who they are. They still say, "Hi, Dr. Ramsey in the grocery store" to me. So it's important that you give that positive image and are sure to talk to those people, because when they trust you, they're going to be compliant. They're going to have better outcomes from their treatments. They're going to listen to you and actually uptake that information better than if you're an anonymous person otherwise. Yeah,
you're doing some great things at your health system, and one of them we talked about is, you have a videographer, you're telling your patient story, telling your story. In that, how do you feel the trust is in your respective community? Have you heard about this phrase, fraud, waste, and abuse? And how are you addressing it specifically? What would you say to the new leader today who's like, how do we deal with it?
Yeah, so the terms fraud, waste, and abuse definitely are out there, especially in certain political circles. Most rural America is very strongly red Republican. And along with that, you just need to really sell to your community that you're not partaking in any of that. And that's just a lot of the rhetoric out in D.C.
It is.
So once people see that, once they utilize your services and see that you're not wasting and abusing any of the system, they are very appreciative of that and really grow to love you.
But do you find, though, that you have experienced a greater departure between the relationship between the patient and the provider as it relates to trust?
Absolutely. Yeah. And there are certain topics that come up, especially around vaccination, that patients just flat out refuse, and physicians, myself included, and several others that I talk to, it's not a fight you're going to pick anymore. Before, I used to work to convince people to get immunized. Now, if they say no, you don't even go there.
I think it's a great point that you bring up, because I was attending a Becker's Healthcare Conference, and Randy Oster and I were together, and he was the former CEO of ProMedica Health System, and it was probably 15 years ago, and I heard for the very first time the phrase social determinants of health, and I thought,
such dirty words in D.C. right now.
Right. What is that? That's a fad. That's something, the importance of that, social determinants of health. If you don't have food, you have food insecurity, you're not going to heal well.
Absolutely.
If you don't have access to medications, talk to us about how that broken trust and that fragmented trust among providers, and maybe it's not providers, I don't want to pick on providers, let's say health systems and patients, impact social determinants of health. Can you talk to us about that?
Absolutely. First off, they're the only ones who likely are going to identify any of those social determinants of health needs in patients. When patients walk in to see a doctor, they open themselves up like they do nowhere else in the world.
Right.
So you're one of the few places that people will actually express concerns over that. So we do have some community health workers that we're able to refer patients to because physicians won't have the time necessarily to talk with them about that. And that does really help connect them with resources in the community. If you're taking care of that, you're going to get a lot more benefit to the community than just their health needs as well. You're going to have a much greater thriving community, and both economically and physically.
Yeah. You know, we look at some of those issues, and I'm sure you face it in your community, especially with 70% Medicaid, Medicare, food insecurity, the role that plays. We are now asking, and have been for several years, we fill out a form, social determinants of health, right? And we're asking the important questions. In the last month, were you able to pay your rent? That plays a factor. Did you have access to food? Did you have housing? And your organization, I'm sure like ours, takes it a step further. If we identify those, we're trying to put them in with a counselor to work with them. We see that happening. That's part of how we build trust, but I want to talk to you about how you are building trust in your community. So how do you bridge that gap? You know, for perspective of what needs to happen for trust to be rebuilt. We know that the trust has been somewhat eroded over time, and as politicians talk, it's even greater. As we have individuals coming in and we have to build them, right? That's a level of trust because unfortunately, if they don't make the payment, we have to have conversations, right? And so what advice would you give healthcare professionals listening today who want to start repairing trust with the community? What steps should they take? What actions should they take? Where's the starting point? And can it be, do you think trust can be once again restored in some of these communities?
I do absolutely think that it can be restored. And really, it's important to get out there and have those conversations. It's important to get out to local clubs and organizations and churches, places where people gather, and show that you are a resource for them. Provide resources in those areas, and they will start to really cling on to that and gain trust back.
Rural hospitals right now, we're taking a beating. I would certainly call your hospital a rural hospital. 30,000 residents, I believe you told me. That
in the
county. Serving a significant need in rural America. But we're hit with an onslaught of a lot of challenges right now. I'm sure you told me you have 6 pharmacies.
Absolutely.
So you have 340B.
Absolutely.
I'm sure you're battling 340B. Let's talk about that because that's a hot issue right now, and this is a national podcast. Let's get a plug in.
Taking a huge hit right now, especially with all the new implications that went in place January 1 of 26 here. We're taking a bath on that. Unfortunately, that really limits access to meds to a lot of patients, number one. Number two, we do utilize some of the monies that come in with that, not just to keep the hospital afloat, but provide other services too. That's how we provide care for inpatients in the county jail, as well as their medications while they're there. A number of different things throughout the community that we leverage those dollars for.
Did you, so can you give numbers? So, for example, Hillsdale, we went from 3, and we don't have a big presence, but we do have 340B presence, but we went from $3 million down to about $600,000, $700,000 a year. That impact is significant to our operations. Did you experience that drop, that significant?
We've had a drop worse this year than in years past.
Yeah.
It's still early in the year to know those exact numbers. But it definitely made an impact. I don't have those exact numbers right offhand for you.
But we know Washington's talking about it right now, right?
Absolutely.
And who is pushing more for this? Obviously, Big Pharma. And you want to comment on, what our listeners should do to be advocates?
Absolutely. They need to reach out to their legislative folks, tell them the importance of preserving 340B. 340B is not paid for by taxpayers.
Right.
It is paid for by Big Pharma, and Big Pharma is lining Wall Street's pockets.
That's right.
They are taking a huge chunk of money out of healthcare, huge chunk of GDP, and lining Wall Street pockets with it. So it's some of those dollars that otherwise would go straight to the Wall Street pockets that are actually coming back to your communities. It's not costing the taxpayers a thing. In fact, it's saving them money because they don't need to come up with extra tax dollars to cover those services.
Could you give us one program that 340B impacts that would have a dramatic impact on the social determinants of health in communities if it went away?
Absolutely. So for us, we have school clinics in 6 different schools where the hospital ultimately foots the bill. to have a nurse there every day. And we've seen a decrease in absenteeism from school.
Wow.
We've seen attendance not only improve, but students are, when they're there, actually more engaged in the classroom than when they're not able to see the nurse. So there's someone who's there who is able to tell when a student just wants to get out of class versus when they're really sick.
Yeah.
So it does make a huge impact across the entire community with those dollars that we're able to help fund that.
One other area we're seeing, do you have oncology services?
We don't, unfortunately.
Yeah. So one of the areas we're hearing across the country is the impact to patients who need infusion chemotherapies and drugs. That is a major impact. So right now, Washington's debating, obviously, those issues. Politicians are, on one side or the other, and the political action committees are working very hard. A disproportionate share. Does your hospital participate in that prior to the Medicaid expansion?
We did have some dish payments.
Yeah.
Obviously, that's phased out now.
That's phased out, but we may be phasing that back in, right? Depending on what happens. So let's talk about, lastly, the impact of the One Big Beautiful Bill to rural communities, because this should be, a political agnostic of sorts, because what happened is there was the passage of this bill, $1 trillion removed from healthcare. I want to talk to you about the impact of what that looks like in your community, because in my community, 72% of the payer mix is Medicaid, Medicare. Programs like obstetrics, which I don't believe you have obstetrics, but we do. And, the impact of the Medicaid reductions, because the majority of the patients in rural America in OB are Medicaid, 70 to 90%. And so when you reduce those reimbursements and the cost of delivering the service is more than you get reimbursed, it's an issue of economics. You can't continue to give free services. But the One Big Beautiful Bill has some major implications here in Michigan, because Michigan was an expansion state. We have what's called the average commercial rate, which means we have, among the states, the average commercial reimbursement for whatever it is would be what we get from a Medicaid payment. And there's a calculation, a formula, which means that actually delivering the service, you might break even or actually be somewhat profitable. Without a margin, you'd have no mission. So we still have to be somewhat profitable, increase staff wages, those type of things. So from your perspective, you're a physician. You see both sides of it. You see both the faces of the patient. Then you walk over to your hospital and you see the impact to operations. Talk to us about what the impact's going to be from this passage.
Well, we know, unfortunately, patients are still going to come, whether they have insurance or not. But we're not going to turn away those Medicaid patients. So we'll continue to take care of them. However, it's going to make an impact. And if there's service lines, for instance, you mentioned OB at your hospital, that are almost primarily Medicaid, we're not going to have an option other than to potentially cut some of those services so we can stay afloat. We need to continue to give wage increases to our employees. Cost of living's going up everywhere, yet we do need to continue to give increased wages to stay competitive so we're not losing our entire workforce to other industries either.
That's right. A lot of challenges.
Absolutely.
So what can we empower the listener to do regarding this?
Again, we need them to reach out and advocate for rural America. Tell them we need those dollars back to rural America. We need to reverse the effects of H.R. 1 on Medicaid because whether you think so or not, your neighbor may have Medicaid, but they're usually very proud and don't want to admit that. But more people have Medicaid than you would think.
So Scheurer Health, what are you going to do in the foreseeable future to offset these losses? Do you have a growth strategy in place? What are you doing?
Yeah, we're working hard to grow other areas that aren't impacted by the Medicaid cuts because they're primarily not Medicaid patients that use those services. We're trying hard to grow those services to keep our other areas afloat so we don't need to cut services. But it's a very fine line, and when the rubber hits the road, we may need to do that.
We've talked a lot about all the doom and gloom. There's certainly a lot of that out there. But as we wrap up today, I want to focus on what's exciting for you right now in healthcare. I mean, you're young, you're a physician, you've got great progress happening at your hospital, building projects. It's a wonderful work. We have to focus on some positive. Talk to us about some positive things happening at your organization.
Absolutely. So never in the history of our organization have we had as many services available as we currently do.
It's incredible.
A lot of patients, like we talked about, can't transport far away, or they just simply choose not to because they don't want to drive to, as they call it, quote, the city to get services. They're literally afraid they might be shot and killed if they go to some areas.
Very true, yeah.
So they'll just forego care. So by bringing that care to them and having those services locally, we're able to provide that. So in the last several years, we've added ophthalmology, we've increased our orthopedics, we've added urology, we've added just a whole host of specialties that really allows patients to just simply stay in their community and really increase the amount of employment that we provide to the community as well. I get very excited when we get our reports on our 401k plan and how much people have actually saved for retirement, because those dollars are going to stick in your community.
They are.
As you look forward. So to see that number go up every year, it warms my heart knowing that gives stability to the community long term.
Yeah.
That means nothing to me as a hospital administrator, other than I know my people, when they retire, are going to be well taken care of.
That's great news. Well, healthcare is fractured. We know that. That's why we launched the series. But what's great news is that the glue that you're putting back together to make sure that we can rebuild this, that there is hope. There's opportunity, bonding with our patients, having meaningful conversations, accentuating the positive things that we're doing, contributing back to the local economy, telling our story, both from a community perspective as well as a patient and employee. It sounds like you're doing all those things at Scheurer Health, and you're doing a great job at it. I want to thank you for joining us today on this episode of Rural Health. And what I'd like to do is wrap up this segment with something that we're doing now, and we posted on ruralhealthtoday.com on our website, and it's called Rural Health Recommendations. What I'd like from you is there's young leaders that reach out to us all the time and say, how do we make it today? I mean, there's a lot of uncertainty. I think the average life of a CEO now is 3 years, so a lot of turnover, a lot of new faces, a lot of people that will turn over. What recommendation would you give a new leader? Maybe it's not a CEO, maybe it's a C-suite. What should they do today in this tumultuous environment of cuts, waste, fraud, and abuse mantra, of just the challenges of, will my community hospital close? What recommendation would you give?
Yeah, I would recommend that you use your public figure and leader status to proactively build trust in your rural healthcare system. If you don't, someone will fill that space with negative perceptions out there. So it's really important to go out and advocate, not to necessarily legislative folks, but just your community in general.
Absolutely. Great recommendation. Thank you. It's been great to have you here, Dr. Ramsey, and certainly at Scheurer Health, you're doing a phenomenal job. Keep up the great work. We need to preserve the corners of our communities. When you lift your voice, you lift the voice for us across the country. And I want to encourage you to continue to do that. You've got a lot of lofty recruitment going on. So if someone's listening today and they're looking for an opportunity in a beautiful community, right? Lakes
right
all around
on the
your
lake,
waters.
Huron.
My goodness, Huron and
Absolutely.
beautiful sporting events. Now in the winter, I just drove up here. It's a little chilly. The roads aren't the most desirable, but if you love snowmobiling,
yeah, it's a great place to be.
I think that could work. So it's been great to have you, Dr. Ramsey, on this podcast today. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health every Monday, wherever you get your podcasts. Don't forget to check out our latest episodes and resources from Rural Health Today at ruralhealthtoday.com. And make sure you've subscribed so you never miss an episode. Until next time, remember, Rural Health Strong.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.